Are you sure
Quarantine.
you want to go there, Chris?
Yeah, I don't. Anyway, so Don, what did you think of the?
Well,
Welcome once again to Free Associations from the Boston University School of Public Health, the Public Health and Medical Journal Club podcast for anyone who is confused by the latest health study, as I am, by airplane filtration systems. Have you guys flown anytime recently?
yeah.
Nope.
Do you really believe that the air in the plane is being completely renewed every 2 to 3 seconds or whatever they claim is happening?
I tested that theory by lighting up a cigar on my last flight, and
How'd
they
it
yelled
go?
at me.
They did?
No, I didn't do that.
Oh,
But I bet it would not have worked.
I bet it would not have worked. What do you guys try? I mean, so flying obviously in the era of COVID is very different.
Right.
And so I part of me feels like there's no way the air can be as good as they claim it is. On the other hand, we don't hear about a lot of outbreaks that have been happening on planes, which suggests they probably are pretty decent, right?
Well, hard to
there's-
measure an effect given all the other things.
Yeah. But
There are some classic ones. I mean, there's a very famous TB outbreak where they identified it within various rows of the index case. So it happens.
And there have been COVID ones as well. I just
Right.
feel like because people are so paranoid about flying, that if they get sick after flying, they're going to assume it came from the plane and they're going to report it. And so we would hear about it if it was a common thing. I don't know. That's just my theory. Anyway, I am Matt Fox from the Departments of Epidemiology and Global Health at the Boston University School of Public Health. I am joined, as always, with Dr. Christopher Gill.
From the Departments of Global Health and Global Health.
Both of them. You got a second appointment in
you
Global
have
Health?
Plural.
I
I'm
know,
going for plural.
but you have 2 appointments in the same department.
That's right.
Welcome, Chris. And Dr. Don Thea, also from the Department of Global Health and the Department of Global Health. Welcome, Don.
Matt, Chris,
Hello.
Nick.
Hey.
Hello, Nick.
Gentlemen. As a reminder, head on over to the Population Health Exchange website at www.pophealthex.org. We use Hub for Lifelong Learning. Nick, do we get any feedback on how many people go to the website specifically? Because I say it every 2 weeks.
Is there a spike on the day after?
Nick is saying that the day after we record, apparently it goes up 1,000-fold.
Apparently
so it's
it
really
drops significantly every time we recommend it.
Anyway, you can head there. You can also give us a rating on your favorite podcast app if you are so inclined. So let's move on to the show. So today, in our first segment, which is our Journal Club segment, we're going to talk about a study that looked at the impact of daily COVID testing in schools to try and keep kids from having to isolate when they are exposed. Then in the second part of the podcast, which is our deep dive, we'll talk about COVID-19, health equity, and wicked problems.
Whatever that means.
Wicked problems.
I was thinking, is that the musical or are we talking Boston?
We're talking Boston, I think.
Okay.
And
Big bad problems.
wicked big problems. And in our final segment, which is our amazing and amusing, we'll get into some things that make us laugh out loud, or Don will just butcher the name of amazing and amusing. All right, so segment 1. So we're going to talk about an article which looked at the impact of in the UK of daily COVID testing for kids in school who were exposed to someone who was COVID positive. It was published in The Lancet, and it was entitled Daily Testing for Contacts of Individuals with SARS-CoV-2 Infection and Attendance and SARS-CoV-2 Transmission in English Secondary Schools and Colleges, an open label cluster randomized trial. I believe, therefore, taking the prize for longest title that we have read so far. It was by first author Dr. Bernadette Young of the Nuffield Department of Medicine. Some headlines on this one, because it did get a bunch. So New York Times says a new COVID testing model aims to spare students from quarantine. Forbes says new testing protocols in schools may minimize student quarantines. Axios says more schools using test to stay strategy to minimize quarantines. That one was based on the article, but it was a larger article. And then Vox says a simple solution to the endless school quarantines, which I thought, by the way, I have to say I'm impressed that we have now reached peak COVID where people now actually know the difference between isolation and quarantine, which is pretty awesome.
Oh, those armchair epidemiologists out there.
Yeah. All right. So, Don, you're going to talk us through this one. What did
No,
they?
is that Don? Is this Don?
Yeah, it's me.
Okay, you're right. I'm doing the other one. Next week, in 2 weeks.
In 2 weeks when you come back.
That's right. That's right. Well, the first thing I had to do in going through this paper was go right to Wikipedia to find out what is a form. A sixth form and his
It's grade,
seventh
right?
form. Yeah.
Grade.
I had no idea what they were talking about because they're talking about grade schools, they're talking about secondary schools, they're talking about colleges, they're talking about public schools, which are fee schools. It's like a completely different system over there.
It is weird to me. I knew about the forms, but the thing that is weird to me is that public and private seem to have the opposite meanings.
Exactly opposite.
What we think of as a public school is there a private school.
Right.
And vice versa.
Right.
It's weird.
The other thing that's a little funky is that when they talk about colleges in this, these are like usually 1-year transition to university programs. They're like an extension of high school for people who
It's
are
almost
heading
like
to
1 year
university.
junior college.
Exactly.
Sort of.
It's
Yeah.
not like what we think about like going
Right.
to Tufts or going to Bates,
Right.
or going to Antioch.
So what they're trying to do in this study, I think, is trying to find a way to minimize the amount of time that kids are put into quarantine because they have had a contact with a known case of COVID, either amongst a schoolmate or staff member at the school or somebody at home, or it doesn't really matter where. But the convention had been that these kids have to be removed from school and quarantined for 10 days or so and tested multiple times. And what they're trying to do is they're trying to minimize that because of the obvious impacts socially, educationally, and on mental health for kids being taken out of school. So with the advent of rapid diagnostic tests, which they have available in England to a much greater extent than they have here, unfortunately. We can go down that rabbit hole for a long time. But they took advantage of the availability of these rapid tests to set up an experiment, a cluster randomized, open label study where they took a bunch of schools and they randomized them to different groups. One group where there was a known contact with a proven COVID case. The child would be enrolled if they were in the intervention arm, they would do daily testings with these rapid diagnostic tests with the idea that as soon as that test becomes positive, then that child is a known transmission case and would be therefore isolated. Versus having those children not be tested on a regular basis, but being removed for the usual 10 days.
Into quarantine
As opposed to isolation. So it was a cluster randomized open label 1-to-1 allocation study. There were 201 schools that were randomly assigned, 99 in the intervention and 102 in the control arms. They randomized by school type and size, presence of sixth form. I guess that is the higher grades. So they wanted to make sure that the population of the students in the two arms were well balanced. Presence of residential students, because some of these schools are sleepaway schools, and the proportion of eligible for free school meals, which is a proxy, I think, for socioeconomic status. And so all schools were offered 2 times per week rapid diagnostic tests for children who had new onset symptoms. And if they were rapid diagnostic test positive, they would get a follow-up confirmatory PCR for confirmation. The study ran 10 weeks from April 10th to the end of June 2021. So it was during a period of time in England when there was a low to moderate community transmission of COVID. So it wasn't really hot in the communities. There wasn't a lot of transmission going on. Their outcomes were COVID-19 related school absence, so a kid who actually got infected and then had to be isolated, and then symptomatic confirmed COVID-19 cases. They adjusted for community case rates because there's 109 different schools and there's local differences in community-based transmission. And they set it up as a non-inferiority test with a margin defined as less than 50% relative increase.
which seems
pretty
huge
wide.
to me.
Yeah, it is pretty wide. It is pretty wide. And it was an intention to treat analysis. And they did something called the compiler average causal effects, which Matt is going to explain in excruciating complier average causal effects. Matt's going to describe that to us.
Case model.
Whatever that means.
Or
So what were
khaki.
the results? So in the intervention group, they managed to get 2,432 contacts to do the daily testing. Not everybody in the intervention group were compliant with it. So it was about 42% of the contacts actually in the intervention group actually complied with the intervention. There were 657 symptomatic cases in the control group, 657 symptomatic confirmed infections during 7.5 million days of observation at risk. So that's about 59 cases per 100,000 per week. In the intervention group, it was 740 versus the 657 in 8.3 million days to result in a rate of about 61 cases per 100,000 per week. So the incidence rate ratio, there were several, but the one that I understood was 0.96 and a confidence interval of 0.75 to 1.22. So in essence,
No difference.
There was no difference. And they were able to show that, in fact, there is an advantage to this kind of an approach, because if you can manage to get kids to agree to and comply with testing on a daily basis, you can keep them in school instead of quarantining them for 10 days. So
it's powerful.
I think it was a really interesting study. I thought it was pretty well done and came up with a very useful outcome, you know?
Yeah, I would certainly agree with that. I mean, whenever I see a non-inferiority trial, meaning the study is not designed to assess a benefit, because we don't expect necessarily for there to be a benefit, although there could be.
We just want it to be not cause harm.
Not worse. Because we think there will be a benefit in terms of the kids being in school. I always want to see, or it'd be nice to see, some kind of a cost-effectiveness study, because obviously it is more expensive to do the daily testing. And so you do wonder whether it's worth it. On the other hand, you also have to factor in the value of the kids being in school, so it gets hard to do.
Yeah, I mean, you could do educational attainment on a kid-by-kid basis.
Yep.
That's something, you know.
Absolutely.
How much were they penalized for being out of school for those 10 days, maybe even a couple of times in a semester?
Absolutely.
Plus one of the things is that the cost of rapid diagnostic tests is a function of the uptake of rapid diagnostic tests. And so right now they're relatively expensive because nobody's using them.
Here, but not in the UK.
But like I was just going to say, if you like ramp this up on a massive scale, then, you know, the cost would be, you know, so that like doing a cost effective analysis is tricky, because you have to assume like what would be the cost if we actually did this at a you know, all schools in England.
Agreed. Although, I mean, the cost of rapid tests in the UK is
cheap.
Very, anyway, so Chris, your overall take on this one?
Oh, I thought this was so cool. I have a couple comments, some of which are a little bit snarky, but the first one is that this was a pragmatic trial that, God bless their hearts, they didn't mention the word pragmatic once, because most of the studies
Which made you happy?
Yeah, because a lot of the studies we've seen that brag about being pragmatic are kind of like not really all that pragmatic.
I want to see you. I want to see you publish a non-pragmatic trial. I want you to call it that.
An impractical trial. So, and anyway, my second comment is that I was impressed the fact that it achieves its two primary endpoints of like showing there's really no harm in terms of increased COVID infections, and at the same time you are, you know, reducing the number of sick days. And so there was kind of a win-win. The economics we can debate.
Sure.
The other thing it struck me about this is that this is the Michael Mina trial, right? He has been banging this drum, and here is finally empiric validation.
Explain who that is.
So Michael Mina is a professor over at that other school in town. Not Tufts, the other one. The name
Boston
escapes
College?
me.
He actually just left.
He did?
Yeah.
Okay, so that he's not even at that school.
No.
Whatever they're called.
He's a scientific director of
Haverford or something.
No, a new company.
Oh, really?
Yeah.
Anyway,
Diagnostic company.
Haverford School of Public Health, isn't that nearby?
No.
Anyway,
he's been a strong proponent of.
He's been a strong proponent of the
tests.
idea of like, why don't we use a daily diagnostic test to rule in the ability to go to work? And his argument has been that the lack of sensitivity of these tests is an asset, because all you really care about is whether they're pretty contagious or not. And if they are positive on a rapid antigen test, they're probably wicked contagious. So we could work in that word there.
Wicked good.
Wicked good. Whereas if they're negative, they might still be positive on PCR, but who cares? So this is sort of like, you know, it's a simple strategy. If you could scale it up, it has all sorts of benefits. And here we see empirical validation of this theory at last. Well done.
I think it's important also to note that approach works because we know that people who get COVID tend to have very high viral loads.
That's right.
It goes up very, very rapidly. So you could be below the level of detection for the rapid test, but be PCR positive in the morning. By the afternoon, you're likely to be positive in both because it happens so quickly.
But what the PCR gives you is that long tail of positivity
When
that
you're not
clinically
infectious.
is probably not important in terms of who's going to get infected next. So I thought this was very clever. I also thought it was interesting that the benefit was demonstrated despite kind of crummy adherence. 42%.
So
I think
we got
is
to
what.
talk about that.
Yeah,
What I mean, 42% adherence
it's not great.
It's not great. And so this gets to, Don, you brought up the complier average causal effect. Essentially what they are doing with that analysis is they're doing the, you know, what you probably think of as like the per protocol effect. Like what would happen if everybody complied? And the answer is there would be an even bigger benefit. But I don't know. I don't know that I need to, I don't know. It's not that I don't want to know that. I do want to know that. But they couldn't get more than 50%
so
to
this is where it's
comply.
pragmatic. It is what it is.
Yeah.
This is what it looks like.
But they don't tell us why. I mean, what I mean, maybe they probably don't know. But it strikes me as important to recognize that they could only get about half of the kids to comply with this policy, and it still didn't matter.
Yeah, in fact, it might have been a much more useful analysis to imagine, like, if this was done outside of a trial, you would imagine that adherence would not be better. It would be probably worse.
Exactly.
So wouldn't it be more helpful to model, like, what if it's only 30% compliance? Would you still achieve the benefit you're looking for? Mm-hmm. You know?
And so to me, that was something that really stood out. I mean, as you say, I don't know how much it matters because they found potentially a benefit, mostly no harm. And this keeps kids in school, which is ultimately the goal. It does potentially cost more, but I think it's an investment that presumably people would want to put in there. I was a little surprised that one of the primary outcomes was days missing school, because, I mean, isn't it a given that if your two policy comparisons are go home and isolate versus stay in school, it's going to be better for the kids.
Until you're infected.
It's obvious.
You're going to, it just strikes me
stacking
as
the deck.
Unless compliance was so poor that you couldn't make it happen.
But even then, it's a non-inferiority trial. So if you couldn't make it happen, you're essentially probably back at the old strategy, in which case it's
a wash.
It's a wash.
Yeah.
And that's fine. I mean, if you're keeping more kids in school and you're not having more, but what matters is the transmissions then.
That's right.
And so that's, to me, where the important part of this study comes in is, are we reducing transmission? One thing I wanted to ask you about is they do make a case in here, but they never really follow up on it, from what I could tell, that part of what this policy might do would get more people to report symptoms, because or exposures, because you wouldn't essentially be penalized for it. In fact, you would get access to testing.
You're destigmatizing
it and allowing kids to stay in school. So you could raise your hand and say, and then potentially you might pick up more transmissions that potentially would have been asymptomatic, but you might have less onward transmission. And I felt like they didn't really follow through on that. I would have loved to have seen more on that, just to know whether or not it had any of those other benefits.
Mm-hmm. There were two interesting points that were buried in the paper that I thought warrant sort of underscoring. Mm-hmm. They as I said, they offered 2 times per week testing for anybody that wanted it. So they were able to pick up a bunch of cases. And
using the RDTs, not PCR, right?
But then if the RDT was positive, it was confirmed by PCR. So they identified a certain number of those sort of organically happening cases in the class. And it turns out that 1/3 of the asymptomatic PCR positive cases became symptomatic, meaning 2/3 remained asymptomatic. But that kind of blew me away. That really underscores kind of what we knew, but it's of a greater magnitude than I had thought. 2/3 of the kids that were PCR positive started at asymptomatic, remained asymptomatic. They never would have been picked up.
Do you think that's because it was kids? I mean, that if you looked across the entire age distribution, it wouldn't look like that?
Possibly.
Yeah.
I mean, they're more resilient, So that's probably part of it.
But I agree with you. I mean, but that has really big implications for, well, maybe not so much now, but certainly back when we were debating whether or not to send kids back to school here in the U.S. without really testing them, that you could have a lot of transmission that nobody's picking up that then gets taken home. Now, that was pre-vaccine, so I don't know if we think about it in quite the same way. But
and certainly it has implications for the staff and the older teachers, especially if they have comorbidities. The other tidbit that I thought was really interesting was that they stated that contact case transmission occurred only 2% of the time.
Really low.
2% of the time.
It's really low.
That's just amazing, and we're seeing rates that are astronomical in prison. We're seeing rates that are really, really high in other kind of confined spaces like cruise ships. 2% kind of blew me away. I thought that was extremely low.
Yeah, again, I do wonder if that's anything to do with the fact that it's kids and whether there's, anything to that. Plus, if you're having lots of asymptomatic kids and you're also having, kids just maybe with lower levels of infection, so they're not spreading as much, virus or shedding as much virus. But if I understand, it's about 15% in household contacts that tend to get infected. So 2% would be substantially lower.
I think it depends on a lot of things in terms of household context. There was a paper that I just saw this morning. I don't have a reference for it, but it was an elegant way of looking at in-household transmission events. And they looked at households that had one unvaccinated individual versus a number of other household members who were vaccinated, and the number of times that there were transmission events. And the more vaccinated people in the household, the fewer transmission events that occurred in the household. So, it depends. Like so many things, it depends.
Yeah,
in terms of household transmission.
I think I know the data that you're referring to, and it definitely lends some credence to the theory that vaccinated folks are less likely to become infected. It's not a sterilizing vaccination, but it clearly there is benefit. The other thing I want to ask you all about is how generalizable do you think this finding is, in the sense of it strikes me that there is a fair bit of context here. One is, as you say, they were doing twice a week testing, so that was sort of part of the standard of care across both arms. It was done, as you said, during a period of relatively low transmission in the UK. And, everything is just context specific. I mean, depending on the schools you pick, the ability to enforce these policies might be very different depending on where you are and how much resources you have access to. So I just wonder, whether you think this is something that says it can work, or does this mean it's going to work in almost all cases?
I think it's going to be very context specific. I think it's going to be very dependent upon the amount of community transmission that's going on. If it looks like it probably works for low and moderate transmission, but I think if it gets much more intense than moderate, I can't imagine it's going to work.
Mm-hmm. One of the things that I didn't see in the paper, and maybe I just missed it, was some description of the mask compliance rate in these schools, or whether they were even using masks in these schools. I didn't see that anywhere. Did you guys spot that? Because
I did not.
It might speak, for example, to the very low case contact transmission rate of 2% if they're all wearing masks all the time. But I actually don't know what England was doing then, because there was some relaxation of the mask mandates in the spring. So I know that felt like there was a curious admission, because otherwise you're right. Like the transmission rate seems remarkably low. But of course, if they were all wearing masks, then maybe that's not as surprising.
Yeah, I don't know that we got any information on that to be able to judge.
Yeah.
The last thing I want to go back to is the thing we raised while you were introducing the study, which is the non-inferiority margin.
50%.
Yeah. No, I don't want to make a big thing out of it, because I actually think it turns out with the data they had, I'm convinced. But it is interesting to me that they set a non-inferiority margin of 50%.
Which you could drive a truck through.
Meaning, in order to say that this is no worse than the policy that was in place, it could be up to 50% increase in whatever the outcome is.
Yeah,
is that,
twofold increase, 50% reduction, right?
No, I thought it was 1.5 for like 50% increase. But either way, it's a big margin, and they go on to state why they did this. So they said the challenge with setting a non-inferiority margin for transmission events is that the margin's meaning is highly dependent on the control group event rate. And I thought,
true.
That is true only if you define it in relative terms. But if they had defined it in absolute terms, you could define a transmission difference. Now, that's hard, of course, because transmissions are a rare event, but it still seems to me like you could do it. But anyway, I think you could define probably the same thing in a way that was a relative difference that would appear much more believable, even if it was based on the same 50% number. And we would probably not blink, not look at it twice. But it just 50% felt large.
Yeah, they must have been very, very ambivalent about what they were expecting to see to take such a margin of equivalence.
I wondered that, or I wonder if they just didn't have the sample size, because I mean, I didn't go into this thinking there's any chance that this is going to decrease attendance. Mm-hmm. I suppose there is the potential that it could increase transmission.
Sure.
But yeah, so maybe, and I guess you're probably right. That is probably why. So they were willing to tolerate some increase in transmission to be able to keep more kids in school. Okay, yeah. So that strikes me.
A final point that's a total triviality is the introduction of a new verb that I've never seen before.
What's that?
Trialed.
Trialed? That's a verb?
Trialed. Trialled. Trialed. This was trialed. I've never heard that before.
It's a perfectly cromulent word.
Are we guiling and gimbering in the Wabe?
I think we may be. I think we may be.
So I just did a search on mask on the paper, and it says that routine mask use was discontinued during the trial on May 17th, 2021, but other precautions were maintained. So during the initial 1/3 of the observation period, routine mask use was in place, and then it was discontinued.
But does that mean they didn't wear masks?
That's all
a good
they
question.
say. So we don't know what the level of compliance with that
know the
is or
mandate.
non-compliance.
Yeah, so that seems to me like an interesting part of the story that we'd like to know more about.
Yeah.
Yep.
They do refer to masking, but that had to do with the blinding.
Blinding.
Yeah.
Yes, they do. They do refer to that.
So they literally blinded them by putting
They
masks
did
on
not.
them, and
They,
That's right.
They
you
did not put the masks over
spin them
their
around
eyes.
in a circle and say, "Okay, go that way," and
And try not to
Try not to get
infected.
COVID?
Yeah, I think that's what they did, Chris. Yep. I do have to. There's one thing that did bug me. So I'm going to read you a sentence. On an intention to treat basis, blah, 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 we can be 97.5% confident that any increase in the rate of symptomatic infection in the intervention group did not exceed 22% more than in the control group. And for anyone who's heard me rail about what the definition of in this case, 97.5%, confidence interval means you cannot be 97.5% confident in anything except the method. Drives me nuts. Okay, that was
I can see why that makes you so cross.
that was for a very select.
Calm down, Matt. Calm down.
Thank you.
No frothing.
I'm okay. I'm back. All right. So let's move on. Unless anyone wants to give any last snarky comments.
No,
Snark-free?
I'm fully snarked.
All right. So
Is snark another Jabberwocky reference? I think it might be.
I'm going to do the introduction to the second segment while you look that up on your phone. Oh, Chris is giving me the thumbs up that it was indeed from the Jabberwocky.
Yes, it's Lewis Carroll. The narrative follows a crew of 10 in the story, The Hunting of the Snark, which is also referenced in Jabberwocky, the creature, whatever it is. We don't know what it is. But he says it's a creature which may turn out to be a highly dangerous boojum. So now we know.
Yeah, no, I feel a lot better now.
It's a kind of boojum.
All right. So in our second segment, we are going to talk about a perspective piece in PLOS Medicine, which is entitled COVID-19 and Global Health Equity for Health, the Good, the Bad, and the Wicked by Elvin Yang and colleagues. And this introduced an idea that I have never come across before, and I know there may be some skepticism in the room, but I will leave that for later. Talking about the idea of wicked problems, and specifically getting at the idea that COVID-19 and global health equity would be a wicked problem. They talk about this for COVID, but they make reference to HIV and the way that HIV treatment access was handled. They refer to Riddle and Weber's conceptualization of this thing called a wicked problem, which they define in terms of 3 criteria. They say wicked problems are problems which have no definitive problem statement because understanding the problem is the crux of the problem itself. Number 2,
Sounds like a tautology to me.
it
Yeah,
does.
I got lost on this one.
The elusive problem formulation precludes a shared understanding of success or even progress by stakeholders. And number 3, the absence of a shared agenda undermines the aligned and effective action. No, I get it. So you both are a little skeptical of this idea, but at least for me, what it gets at is the idea that part of the reason why we are struggling mightily with equity in COVID, let's say access to COVID. We'll talk about vaccines, but you could talk about testing or any kind of treatment. It's because we don't have any shared sense of the problem. That we here in the U.S. are hotly debating, and I guess the debate is now over as to whether or not everybody should be able to get a booster when a large part of the world hasn't even had access to a first dose yet. So clearly, it's true that we don't actually have a shared sense of what the problem is, because some of us think it's perfectly fine that we should be getting our third dose when others haven't gotten their first dose yet. And they make the argument that with HIV, we solved a lot of these problems by defining what the problem was, access to HIV care, and then, having a group of advocates who were very invested in making the case for global access to it. And then number 3, having a clear set of metrics by which we measure progress towards the goals. And they talk about the HIV care cascade, where we,
the 90-90-90.
And the 90-90-90 goals, which the idea is that 90% of those who are infected are identified, 90% of them are on treatment, and 90% of them are virally suppressed. And we don't have anything like that. I mean, you think about like so many of the big global health initiatives have been catalyzed around some sort of set of targets, the Millennium Development Goals, all of these targets. And there is no equivalent for COVID-19 that we're all invested in and working towards. And so it's kind of everyone for themselves. So I share your sense for this idea that maybe a wicked problem is a framing that doesn't add a lot. But I do resonate to this idea that we don't actually have a shared set of goals and metrics that we're working towards in relation to COVID-19. Now, maybe that's because it's an emergency situation and we are just doing whatever we can, but it does strike me that we need something. So reactions, thoughts?
Yeah, I mean, it's hard for me not to get away from the idea that it was just hoarding on the part of the developed world. I mean, at one point, Canada had 4 times the number of vaccine doses for the entire population of Canada. And part of it also, I think, was the fact that India got slammed really, really badly. And the Serum Institute of India is a huge entity that supplies all vaccines for a large part of the developing world, and India made the decision: we're in such bad shape that we're going to hoard our vaccines because our population is really, really having a hard time. I mean, they got hit harder than any other population in the world. So I think those two factors. One, I think, is a little bit more venal than the other, and I think I think that was also true in terms of some of the vaccines that were manufactured in Northern Europe. The other thought I have is that you're absolutely right, and as are the authors, in comparing this to the HIV experience. But the HIV experience happened over 30 years.
Yeah, no, it's absolutely true.
For the first 20 years, there was no real equity of distribution, even after the antiretrovirals were discovered. I mean, when we first started working in sub-Saharan Africa, and we were doing trials with antiretrovirals, it was really a difficult choice because they were not generally available. And there were great debates in terms of how can anybody be doing research under those circumstances when, the $17,000 a year regimen that's being provided to people in New York City is not being provided to people in Kenya. And so very sympathetic to the inequity issue. And if things hadn't happened at such lightning speed for this pandemic, it might have been different. The only other thing is that I think that there is an aspect to the HIV experience that is a little bit different than the COVID experience, because HIV really affected a pretty discrete, vulnerable population, at least in the developed world, much less so in the developing world. And I think that there is a much higher sort of perceived stake with respect to COVID because everybody is vulnerable.
Yeah.
Yeah, I was gonna mention 2 points. One in regard to like the history of HIV. One of the most sort of personally impactful moments of my young career was when I flew down to Washington D.C. to watch the American Academy of Sciences, the Institute of Medicine, having their debate about whether to basically fund HIV drugs for Africa. And it was just such an interesting fly-on-the-wall experience where there's a lot of people in the room, but, the IOM is sort of this horseshoe group of people staring at a podium, and one after another people are giving presentations, and you have these two polar extremes being expressed. You've got the sort of the Steve Deeks camp. He's a virologist who was very concerned about antiretroviral resistance, saying we got to be really careful. We got to be really careful here. If we mess this up, we really mess this up bad. And then on the other hand, you've got like the Jim Kims and the Paul Farmers. I think Jim Kim was there. Paul Farmer was not there, but they're expressing the same position where they're like, this is a life-threatening, this is a cataclysm and we got to move fast. People are dying. There's no time to wait for the perfect solution. We just got to go. And in hindsight, that camp won. We have to go fast. Thankfully, and they were right about this. They were absolutely right. And sort of projecting that forwards, I wonder if we need to again like be so careful of not falling into the perfect is the enemy of the good trap that we so often do in public health. That we're afraid that making a pretty good decision is not, instead of the best decision, is going to be more harmful than, in fact, what we end up doing is making no decision. So that's my first point. And the second one is that I was really struck by this statement in the paper, and I'll just quote it. He says, at present, he's referring to the COVAX initiative. And the COVAX is this group that's trying to, create vaccine access in poor countries. And they say, at present, the working global targets for distribution of vaccine have been put forth by COVAX, an alliance between Gavi, the Coalition for Epidemic Preparedness, and WHO. COVAX seeks to allocate vaccine to cover 20% of the population in all countries. Yet is a 20% floor targeting a success, or is that capitulation to failure? I actually thought that was a pretty good statement.
Totally agree.
Because 20% is pathetic.
It's not going to make it at
It's
all.
not going to do much.
No, it's a really important point, and I'm glad they raised it. I do want to go back to the comparison to HIV, because I think they're the other. I mean, you mentioned perfect being the enemy of the good, but here's a case where what do we need first and foremost? We need vaccines, and we need them distributed, and there's no real issue there, right? We're not worried about resistance to the
Just
virus.
supply chains.
We just got to get it out there. And the second thing is, the other thing is we're talking about a 2 to 3 dose series. 2 mainly, in some cases 1. Whereas with HIV treatment, the debates were around this is a lifelong therapy, so even if we're going to trial it in places with limited access.
Did you just use that word?
Yeah.
Trialed as a verb. Excellent. There it is, twice.
There we go. Funny thing is, I didn't even intend that. If we trial it in places where the need is great, but the access is limited, then we are committed to providing it lifelong for those people. This was before large scale access to HIV treatment was there. None of those things exist for COVID. We're really talking about delivering something we know how to deliver. Yes, there are supply chain issues that are different here. Just got to do it. Yeah. And it just feels to me like the commitment isn't there. And that just, I feel like we need to catalyze people, but it's just not going to happen until, everyone in the US and, everywhere else gets their, second or third or maybe even 4th dose. I don't know. And I don't know how you change that.
I kind of think that we're going to have to wait for the development of the Delta Plus, the next variant that's going to arise because of poorly vaccinated populations that's going to come back and bite us in the ass. And then, then the developed world is going to be perhaps a little bit more convinced, a little bit more galvanized to step it up.
I agree.
And that's really kind of sad that it's not just an ethical issue that would induce us to step it up. It's got to be self-interest, that sucks.
Yeah. So cynical.
Yeah.
Any last thoughts before we move on, Chris?
Nope.
All right. So let's move on to our last segment, which is our amazing and amusing. I'm normally, I put Chris in the middle, and I do that for various reasons, but I'm gonna let Chris go first this time.
Oh,
I feel
okay.
like I'm gonna let Chris let it rip.
I'll be short. Don't worry, Don.
He's going to go downstairs and get a couple cups of coffee, play a little solitaire, take a lap around the block, come back, and
eBay. It's time to update your stock portfolio.
That's right.
On eBay?
Or what is it? E-Trade?
I don't know.
If you're trading stocks on eBay, I'm worried for you.
All right, I got an old sofa, by the way.
Oh, fantastic.
I can get you in early on that. Anyway, my daughter is a junior in high school and taking AP Biology. And she is studying, drum roll please,
the Krebs cycle.
Krebs cycle.
Knew it.
And I like when she
the Krebs
signed up for
cycle.
this, I'm like, I knew that this was coming my way. Because every time, every kid, including me, high school, college, medical school, we did the Krebs cycle, and every time it was like painful.
It is. It's so painful.
It's so painful. Anyway, I just want to remind you that the yield is 38 ATPs for each molecule of glucose, in case people have forgotten.
I wrote a paper on ATP in college.
Did you really?
I did.
Oh,
Can
my
you believe it? What a nerd I was. What cyclic ATP it was. I thought that might be a little bit more exciting.
Well, there you go. I don't even know how it could be cyclic. I guess the phosphates make a ring.
Yeah,
what is it?
yeah.
It's good to have 3 of them at any rate. Anyway, I thought it would be interesting to talk about the Krebs cycle in terms of fun facts about the Krebs cycle.
Okay,
Not about
I think we're
the
both
Krebs
going to
cycle
get a
itself.
cup of
because
coffee.
That is just like painfully.
Please tell me you have like a song about the Krebs cycle or something like that.
I wish I did, but here's the first fun fact, which is that each human every day generates their own body weight in ATP.
Wow.
Their own body weight?
That doesn't seem possible.
What do we do with all of it?
ATP is like the universal energy currency that does everything that
like a Duracell
keeps
battery.
Matt Fox going.
Yeah, it does.
And so it's like, it turns out to be rather important.
Powered by ATP.
Powered by ATP. But can you imagine that? Like, an entire Don Thea made of ATP every single day.
That sounds wrong.
How do they measure that?
I don't know. The ATP-mometer.
They weigh it?
They probably have little guys with pickers
Oh my God.
watching. Anyway, I thought that was cool. The other thing is, who is this Krebs guy? That was what I was really curious about.
Milton Krebs, I'm going to say.
His name is Hans Adolf Krebs.
Oh, I was close.
He was a German-born but British naturalized biochemist who moved to the United Kingdom fleeing the Nazis because he was Jewish in 1933. And this is the thing I think is the coolest. His first report on the Krebs cycle, which we have to admit in hindsight, was flippin' brilliant, right? Because this is turns out to be rather important to everything.
Yeah.
We would not have Don Thea, Matt Fox, Nick Guler, Leslie Solalian, or Chris Gill if not for the ATP Krebs cycle.
It's the cycle of life.
It's the cycle of life. Anyway, he sent this as a letter to the prestigious journal Nature. You've heard of it.
Which one?
Is Nature
Never heard of it.
summarily rejected with his snarky rejections. And that they already had, quote, sufficient letters to fill correspondence columns for 7 or 8 weeks.
So they didn't publish?
They didn't publish his paper on the Krebs cycle.
Did he go on to win a Nobel Prize for it?
He did. Which has got to be one of the greatest examples of revenge, scientific revenge in history. I love it.
Wow.
I wonder if he sent a picture of that to the editors.
Not only that, but he was knighted by the Queen in 1958 and eventually became a distinguished professor at Oxford University
Well
with his
deserved.
own department funded by the MRC.
The Queen loves the Krebs cycle.
He also discovered the urea cycle and some other glycoxylic acid cycle or something. So he wasn't like a one-cycle guy. He was not a unicycle biochemist. He was a tricycle biochemist. And he used to use his tricycle in the courts of King's College.
What did he
Where he could be seen riding around in circles.
Chris, I like that one. That was good. Normally, I find
That part is not true.
Normally, your puns go in a direction that I'm not always on board with. That one I liked. That was good.
All right, that's all I got on the Krebs
Well
cycle.
done. Okay. Don,
38. Remember it.
38. You want to go? You want to go next time?
Yeah, I had, I don't know about you guys, but I had chronically stuffed nose and sinuses. Did you ever have that problem?
Whether either stuffed or they're...
And you take the nasal spray and you get addicted to the nasal spray because you get acclimated to it.
Oh, sure.
You can't sleep.
I
with your
did.
You
nose.
get a rebound hyperemia.
I did
Right.
not get addicted to nasal spray.
hyperemia,
No.
and you have to go cold turkey, and it's miserable.
Oh, man.
Well, I found an article that supports an alternative to nasal spray.
I don't think we're going to like this.
Is it living?
Ear, Nose, and Throat Journal. When is this? This was January 4th, just this year, 2021, by Bulat, Oldacom, and Lippert. And the title of this article is Can Sex Improve Nasal Function?
Probably.
An exploration of the link between sex and nasal function.
No.
Yeah.
No. This is a real journal?
This is a real journal.
This is a real
All
article?
sorts of questions are coming up in my mind.
So they evaluated nasal breathing at 5 different times: before sexual activity, which is the baseline, immediately after sexual activity, 30 minutes, 1 hour, and 3 hours after sexual climax.
I was afraid you were going to say during.
So they found that, in fact, sex is as effective as nasal spray in clearing your sinuses. So they found that
I want a biologic mechanism.
so nasal breathing improves significantly after sexual intercourse with climax to the same degree as after application of nasal decongestant for up to 60 minutes, as measured subjectively as well as objectively, because they used an instrument that would measure nasal flow through the nose. And they were basically equivalent at various times after the act, or whether it's a nasal spray or it's sexual intercourse, except that nasal spray did tend to last longer than 3 hours.
So nasal spray is basically better than sex, is what you're saying.
By what criteria?
This changes everything, Don.
That is news. Why was that not a headline story on CNN?
They had a nasal obstruction symptom evaluation score.
I
and
bet
everything.
you didn't find this like on the hot things on the press from Nature or Science, because sometimes they cover other
No,
journals.
I don't know how I found this.
That is very cool.
Well, that was indeed an interesting one. So as you both know, I love when academics commit to a bit. So I found this on a retweet on Ellie Murray's Twitter, but it was from a professor of sociology, and he was responding to a comment that somebody else had made. I am 99.9% sure it's a joke, but you never know. And he was responding that this particular topic was covered in his course, and they were referring to issues of power calculations, and this is actually covered in his course. And he then tweeted out an image of his syllabus for Soc 710, which is called Social Theory Through Complaining. The course description reads, "This course is an intensive introduction to some main themes in social theory. It is required of first-year PhD students in the sociology department. Each week, we will focus on something grad students complain about when they are forced to take theory. You are required to attend under protest, write a paper that's a total waste of your time, and complain constantly. Passive-aggressive silence will not be sufficient for credit." And then he proceeds to go through a number of topics that are covered in the course.
Oh, that's beautiful.
It can't possibly be real.
I love it when people commit to the bit, Sanjay Srivastava years and years ago had one on fake course syllabus on everything is effed. And it was, people say everything is effed, but how do we define that? And what is the actual metric we use to determine? And
We have to use the F score.
the F test.
Yeah.
I love it. I love it.
Then we'd be significantly effed.
Chris,
Can you
you're
be confident about that?
100%.
97.5%. Wow, you guys are on today. I'm impressed. Well, that is the end of our program.
Thank God.
If you've got any feedback on this or any other episode, or you want to suggest a study or a topic for us to take on, you can tweet us at @PopHealthEX, or you can tweet me at @ProfMattFox, or Don at @DTheo1, or Chris at id.gill, and he'll never see it.
No.
Or you can find us on the Population Health Exchange website at www.pophealthex.org. We want to thank Leslie Talalian, Assistant Dean of Lifelong Learning at the BU School of Public Health, for supporting the podcast, and Nick Guler for sound and editing. Thanks for joining us. We hope you enjoyed it, and we hope you will download our next episode.